Excuse me, ladies and gentlemen, we now have our presenters in conference. Participation in this presentation is by express written invitation of the AHA only. Unauthorized participants and or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call and log off the webinar if the AHA did not expressly invite your participation. Please note that you may submit your questions and comments at any time using the chat pod located to the right-hand side of your webinar screen. It is now my pleasure to turn the call over to Ms. Elisa Ares-Pacachaga.
Thanks so much, Brad, and good afternoon to everyone, and thanks for joining us today. I'm really excited about this webinar entitled Healthcare Burnout, Data-Led Action, to really hear a little bit about the lessons that Minnesota has been able to learn and some of these, and the case example they'll be sharing with you. Been some great work that we've been following, and I'm excited to have it available to all of you. And this webinar is brought to you by the AHA's Physician Alliance. So today, to present today's session, we have with us Dr. Pete Henry, Emergency Physician at Essentia Health, and Dr. Rahul Koranne, who's the Chief Medical Officer at the Minnesota Hospital Association. So Dr. Koranne, with that, I'm going to turn it over to you to share the great work you're doing.
Great. Thank you, Alyssa. And I want to thank the American Hospital Association for hosting this webinar and for continuing to share and learn with us regarding what we're trying to do in Minnesota here. So good morning and good afternoon to all of you. Hopefully we have all the time zones covered across the U.S. So, just a reflection of why we're here. And why we want to pay attention to battling burnout and increasing joy in practice. I do not think it is because of the media stories and the focus that we've been seeing. So that's out there. You all see it in your newspapers and hear it in your podcasts. So that's not the main reason. We will talk about why we are doing this. So here are the objectives for our 90 minutes today. I'll quickly cover the external context around the burnout across industries and beyond. We'll share the framework that we have been using in Minnesota and how and why we started the journey. And then we'll share quite a bit of data. Just a caveat there, there is a data tsunami that's going to be headed your way. Please don't try to track every data point, but just maybe try to get a flavor of what we are trying to do here without tracking every single bar graph, and there will be quite a few, I promise. And then we will talk about the results. And Dr. Henry will join me in showcasing one large integrated delivery network in Minnesota that has been participating and leading this framework in Minnesota to showcase, what is happening in his organization. And we will try to take questions as they come through the chat box, and then also leave some time at the end of our webinar to have a dialogue with you all. So. Let's do a quick introductions for both Pete and I. Pete, would you like to go first, please?
Yes, thanks, Rahul. My name is Pete Henry. I'm the Chief Medical Officer for Essentia Health, and I've been in this role for nearly 7 years. I still work clinically in the emergency department here at our central market hospital, and I thank you for the opportunity to present our information and the great work that the Minnesota Hospital Association is doing around this.
Thanks, Pete. And I'm Rahul Koranne. I'm a practicing internist, and I am a fellowship-trained geriatrician as well. And I serve as the Chief Medical Officer of the Minnesota Hospital Association, and I have been in this role for nearly 5 years. And in my past life, I worked in the smallest critical access hospital in Minnesota for 5 years before joining one of the largest integrated delivery networks in Minnesota. So hopefully you will hear themes of what smaller facilities, mid-sized facilities, large organizations can do and are doing across the state to battle burnout and increase joy in practice. So I'll start a little bit with giving you an overview of the MHA. represent and work with all the healthcare systems across the state. You can see our mission up on the screen here, and I would like to read the vision because that's what drives us every single hour of every single day. Minnesotans are healthy and have access to the right care at the right time in the right place. So that's what this 102-year-old organization, the Minnesota Hospital Association, does every single day. And then I'll request Pete to talk a little bit about his home organization, Essentia Health.
Thank you. So we are an integrated healthcare system that expands over primarily 3 states in the northern tiers of Wisconsin, Minnesota, and North Dakota. Currently, we have 14,600 employees and 2,100 physicians and advanced practice clinicians. We have 77 clinics and 15 hospitals, and what makes us unique, I think, is the fact that we have a very rural footprint. Really the only true metropolitan facilities that we have are in Duluth, Minnesota, and in Fargo, North Dakota, and they pale in comparison to the populations that we're serving, that are served in like the Twin Cities metropolitan area. But it's truly in a rural area, and that has its own challenges, and the size of it, and I'll show you a slide later that kind of talks about that and shows the geographic footprint that we serve. Next slide, please. So a state of 2,100 physicians, advanced practice clinicians, 1.7 million clinic encounters, about 190,000 patient days, 40,000 surgeries, and 164,000 ED visits. I have to also talk about our mission, and we are called to make a healthy difference in people's lives. I'm proud to say that most people in our organization, whether they're clinicians or not, do know our mission statement and our shared commitment around our 3 aspirational aims of engaged and inspired people, 0 preventable harm, and achieve health and vitality in our communities. And the work that we're doing along the resiliency and decreasing burnout is clearly consistent with the aspirational aim of engaged and inspired people. Go ahead, please. So as you can see, we extend from northwestern Wisconsin, northern Minnesota across the state, and into eastern North Dakota. We do also have 2 facilities in Idaho at this point in time that are small critical access hospitals as well. Next slide. I'll turn it back over to Rahul.
Thank you, Pete. So as we think about burnout in healthcare, I think it's good to start looking at the external context, and why not look across the globe first? So this is the United Nations World Happiness Report. It's a fantastic read. Hope many of you read it every June when it comes out. And this is a reflection on hundreds of thousands of data points they have collected around happiness, blue being happy, red being sad. And as you can see, as a people, we are pretty happy, not as happy as the Canadians, but pretty happy still. However, when you start peeling that onion a little bit and you look at the U.S. happiness score, so this is all people in the country, we see a disturbing trend. We see that the happiness score is actually starting to decline. So again, before we get down to nurse practitioners and physicians and PAs and other team members, this is a reflection on people across the country, and that we might all be getting less happy as time goes on. And again, we know, the societal reasons why, but it's just good to remember that context. You also know that across industries, and this is a Gallup study, and it's old, and that's fine. I don't think the numbers have changed, and you track this in your organization. 17% of the employees across the country are actively disengaged. And what that looks like is I'm at work, but I'm working on my resume so I can leave. This will not be a surprise to you. Physicians and nurses lead the list on professions most prone to burnout. And again, we have to contemplate and think about that a little bit. And if you look at data from across the care team members, you will see close to 50% of pharmacists, over 50% nurses, mental health professionals, and physicians 54%, now it's come down just a tad, and we can talk about that. But again, half of our care team appears to be burnt out. And again, if we're not thinking about it, then we certainly should. What does burnout look like? If you're all on this webinar, Pete and I assume that you've been studying this and thinking about this, so you know that burnout is not just a fuzzy concept. It's actually, there are evidence-based around what it looks like. And, Christina Maslach, Michael Leiter, many other internationally recognized scholars have been studying this for many decades. And so you know that burnout across industries and also in healthcare, what it looks like is a nurse or a physician that is completely emotionally exhausted, a physician that when they look at their patient, they're actually looking and thinking about a number and they feel detached, a PA that is driving home after work thinking, what in the world did I do today? Nothing. So that's the definition of burnout, and we have evidence-based emerging that is validating that. So what are the consequences of burnout? Before we go there, I would like to challenge you with a clinical question. So let's imagine there's a stress fracture in this bone here, and I saw this in a podcast or heard it in a podcast and saw, I think, a tweet about this from a physician, and the model is right on. So we can think about, is this normal stress on abnormal bone that caused this stress fracture, or is it in fact abnormal stress on normal bone? So I would like for all of us to just think about, are we normal bone or are we in fact abnormal bone? And we'll contemplate that as we go through this a little bit. Some of these consequences we intuitively know, but I'm pleased to say that there's more data emerging to link burnout with quality and safety outcomes, with patient satisfaction outcomes, with cost outcomes. And then obviously we all know, because we care for our peers and our people, the human toll. And I would like to remind you that there is a continuum of consequences from a suicide on one end to a completely disengaged physician or a nurse practitioner or a nurse or a PA that just is always thinking, I don't care, this is not my job, I'm just here so that I can finish my day and move on. So that's that continuum of human consequences. So in Minnesota, we have thought long and hard about the triple aim, and again, we know that you're all thinking about the new iteration of the quadruple aim, which brings in the volunteers, the staff, the clinical staff, the teams, the coders, the legal experts, the lean experts, the CEO, the board members, so the people in healthcare that are making this industry hum. So that's the fourth of the quadruple aim, caring about the humans that are serving patients and communities. So here's pivoting now a little bit to our model. So our model essentially was about 4.5 years ago, a group of physician leaders, which included Pete, who's on the call with me, in a room, and we started thinking about if we need to work on this, we can't just have hypotheses. We actually need to start collecting data. So frankly, what we have done is we've said we're going to attack and combat healthcare burnout just like we do sepsis and surgical adverse events and falls and pressure injuries and opioids. So basically a quality improvement paradigm. So the first thing we did was we gathered a guiding coalition. And so there were about 15 physician leaders from across the state that came together and said, we must and we will collaborate in combating burnout. And then we assembled an analyst, a survey tool, and the basics of data and analytics to make that machine start functioning. So a guiding coalition is key, and then data analytics piece to really drive that quality improvement piece is key as well. This is where I would recognize Dr. Mark Linzer, who is, as you know, if you study burnout, Mark is a renowned expert out of Minnesota, Hennepin Healthcare here locally, who has worked on burnout for many decades. And so both Pete and I salute him as we talk about the work we've done in Minnesota, because we would not have gotten started had Mark not said to us, here's my Mini-Z tool that is in the public domain. It's for free. As long as you push towards decreasing burnout, feel free to use it, and we did. So it's available out there. It was created based upon an AHRQ grant, and as I said, it is in the public domain, and most of you, I'm sure, are familiar with the Mini-Z. So we've used some of those questions in our survey tool. So essentially, this is what Mark was doing at Hennepin County Medical Center. He was measuring every year the burnout rate across various departments, and he would say, are you going up in burnout, going down in burnout? Then he and his team would go into each department and have conversations. If your burnout score is low, why is that? What are the best practices that we need to spread to other departments? And if your burnout score is high, he would go in and say, why is that? And what can we do to improve? What are the drivers? What can we work on? So it's a pretty simple quality improvement model that he was using across the organization. And then based upon that data, he was doing tests of change. They were thinking about scribes, they were looking at changing schedules, they were redesigning spaces with Schwartz rounds. So interventions based upon what data, repeated data measurement was showing. So essentially, once Mark gave us the tool and gave us his blessing, we essentially expanded that to lead a statewide continuous improvement model. And our model, which is based upon lean process improvement principles with just a little twist. So there's a plan, you make a plan, you go ahead and do the plan, you check the results as compared to the baseline, you adjust the plan, and that's the typical lean PDCA cycle. But here in Minnesota, we also believe in celebrating wins and celebrating work. Even though you didn't get a win, if you tried, we celebrate you. And we have been consistently doing that. So identify an issue, do the PDCAC cycle, and then I want to recognize the American Board of Medical Specialties here and their significant partnership with the Minnesota Hospital Association. And so we became the first statewide organization in Minnesota to become ABMS portfolio sponsor. And so all those physicians and PAs and physician leaders that are actually doing this improvement model do get their board maintenance or certification points. So again, a big thank you to ABMS and their teams for kind of sticking with us and trying out this new burnout-related MOC project. So you may be wondering, what's this tool that we've been using? And I want to make a statement here. Some of the data that you will be seeing is based upon proprietary tools. So please make sure that if you're going to use some of those questions that you do have authorization. If you do use the Mini-Z tool, that's in the public domain, and you can use that. But some of our other questions are part of larger tools that come from Dr. Michael Leiter on the left and Dr. Christina Maslach on the right. And we have expressed authorization from both of them to use their questions. So just make sure then you can look at the data, but before you use any of these questions, you will need to either purchase those or follow the process. So I just wanted to make that comment. So here's what we've been studying. Christina Maslach, as you know, has the MBI, and that's where the emotional exhaustion and cynicism comes from. And then Michael Leiter has been studying burnout and stress across industry, and that's where the drivers piece of our survey tool comes from. So principles around control and fairness and rewards and values. So again, that's the model, the outcome, and more importantly, the drivers. And then we added questions based upon leadership from our physician leaders around thriving factors. We have an open-ended question. And if you have questions about that, there are some certain nuances that you need to have if you have an open-ended question, including very strict governance and a break the glass policy given the sensitive nature of what some comments might be, and we have all that, and then a lot of demographic questions that we can cut the data through. These are all the sites that have been participating, so I think we can be pretty confident that we have a very good look across our large state, and we have a lot of rural greater Minnesota health systems and metro systems. So this is a pretty robust database that Pete and I are going to share with you today. I think I want to highlight here as well for your reflection and contemplation, it's crystal clear if you look at this map and these dots that quality and safety and burnout is not something that healthcare systems in Minnesota want to compete on. And that's something that both Pete and I are extremely proud of. So here's the model. We start with the survey of the frontline clinicians on the top. Then we start this plan, do, check, adjust, celebrate cycle of trying to look at actions, trying to drive actions. We also do a companion survey of the CEO and the CMO to ask them what are the top 2 or 3 actions you plan to take this year based upon last year's data. And so we have that. So if you look at what we have, we've got the prevalence data, we have the driver data, and we have the actions that folks are taking. And so each repeated cycle of measurement, we can start, and we have started matching to validate which actions do in fact reduce burnout. So that is the cycle of frontline survey and leadership survey tied together so that we can discover new knowledge around what in fact works when it comes to reducing burnout. I'm going to start sharing some data, and then I will turn it over to Pete to actually make this come alive and real for you. This was our hypothesis 4 years ago. Again, pretty intuitive that satisfaction and engagement is sitting on the other side of the seesaw to stress and burnout. And so here comes the tsunami. Take a deep breath. Get ready for some fun bar charts and numbers. And like I said, just take a dip in the water. Do not try to read every number. We've got pretty robust numbers of physicians and APPs that we've surveyed. The last survey last year had over 22,000 physicians and APPs surveyed. The response rates have been steadily decreasing over the last 3 years, and I know Pete will talk about that. I will point out that for national surveys, the average response rate is 19.3%. So again, we are confident that this still exceeds that. However, that decline, has told us something, and I will let Pete talk about that later in the presentation. This is the reflection on the burnout scores, overall rankings for each of our participant systems. So imagine each bar is one system, small, mid-sized, or large. They are arrayed from low scores, so that's where you want to be, to high scores. And so this is a journey of discovery over the last 4.5 years to discover who are these 5 organizations and what are they doing, much like what Dr. Mark Linzer was doing at Hennepin Healthcare in each of his divisions. We've just blown this model to an entire state. So it's organization compared to peer organization. And then we obviously worry about these 7 or 8 systems as well. A reflection that with the robustness of our data, we are able to drill into particular departments and specialties within particular organizations. So I can tell you which emergency department across the entire state of Minnesota has the least burnout rate. And we did do that exercise last year, and we immediately went out and made a site visit to try to discover the magic that was happening, and we learned a lot. So again, a reflection on how the data is being used. All right, so lots of data coming your way. Just sit back, enjoy, reflect. Do not try to read the numbers. Just get a flavor of what this shows. This is a very busy slide, and so I've added some arrows for you. This is the U.S. general population, the U.S. physicians, thanks to the work that Mayo Clinic has done, and our survey across Minnesota. So just look at the overall burnout graph and bar charts on the right. U.S. general population is 2011 to 2014, no change in self-reported burnout. U.S. physicians went up, and then more recently has come down. The hypothesis there, as you know, was because of systematization of electronic health records was one of the top reasons why the researchers believed that number came down. And in Minnesota, we were always lower than the national number, and we have pretty much remained the same in the last 2 years that we've asked this question. We did, the next thing we want to reflect on is we ask all these thousands of respondents, what makes you thrive? What brings you joy? And here are the 5 top things that bring you joy, and leading that pack is work-life balance. So again, I will let Pete talk a little bit about what he's discovering with his leadership team at Essentia Health. But it's meaningful work, high-quality care, control, and then come financial rewards. And I would like to draw your attention to the least often chosen a metric or choice for thriving, and that's social connection. So where this is helping us is before an organization starts acting on something, you don't want to start acting on building social connections. You'd much rather act on work-life balance. So that's where this data has been very helpful. All right, so I'll turn to outcomes next. Satisfaction with current job. We're thrilled that we are so high in Minnesota. So again, most physicians and APPs practicing in Minnesota, and this has been validated recently by a national study by Medscape, where they said Minnesota leads the pack across the country in the best state to practice. So very high numbers of being satisfied, very high numbers of being engaged with work. And again, you may wonder, why is that? How is that? And I'll offer a reflection that we're starting to see emerge in our data that correlates high engagement with high burnout. Think of 2 physicians who are both hospitalists. One hospitalist turns off her pager at the end of her shift at 5 p.m. and goes home and is fully present with her family. The second hospitalist never turns off her pager because she's worried about that 87-year-old male with congestive heart failure exacerbation admitted to the ICU. She's waiting, she's watching, she's responding, she's checking Epic. She has a lot of pajama time. So she's highly engaged, but because she's highly engaged, she's also at a much higher risk for burnout. So we're showing a direct correlation between engagement and burnout, and we will keep, we'll keep discovering and peeling that onion. Do you feel a great deal of stress? Again, no surprises here. Very high numbers do feel a great deal of stress. And this is the Christina Maslach's gold standard. Do you feel burnt out? And when you look at the tens of thousands of physicians and APPs that have responded to us, we do worry. Pete and I and the CEOs and the CMOs and other leaders, we do worry about that top box 3% that are serving patients in our clinics, in our hospitals, in our nursing homes, and are saying, I am so burnt out, I may need help, or I'm so burnt out, I am in fact getting help. I'll turn to drivers quickly. And again, this is, outcomes are great, but unless you know drivers, you cannot actually work on them. So this is Michael Leiter and his his research that says values alignment across industry has everything to do with worker stress. So we've been studying that. Again, very pleased with how the values are aligned between clinicians and their leaders. And this could be the CEO, this could be the CMO, this could be the department leader, this could be the board. But again, very pleased to see that. Care team efficiency, high numbers. But I hear Mark Linzer in my brain saying, really, this metric is not, in fact, correlated with self-reported burnout. So this is good, but he is showing, Dr. Linzer is showing that this really does not have correlation with self-reported burnout. Do you have enough time to do what's important? More than a third of physicians and APPs disagree or strongly disagree with that. And then I've peeled a couple of these onions for you. And so when we peel that, looking at inpatient versus outpatient, no surprise to any of you, I'm assuming outpatient is way more burnt out in this particular driver. Do you have control over how you work? Again, a third say they disagree or strongly disagree. Do you believe that resources are allocated fairly? Again, Michael Leiter across industries, not just healthcare, and look at the number, almost a third say they do not believe there is fairness, and that has a lot to do with self-reported burnout for our care teams. Is your organization committed to quality, do you believe? And again, very pleased with those high numbers in Minnesota. That's what makes us and our healthcare systems what it is in Minnesota. So again, very good baseline substrate here to kind of build upon. EHR, I won't talk too much about it because I know Pete wants to do a deep dive in that. But this last year, we really made this a focus. We convened chief medical informatics officers across the state. We asked them, what do you believe we should be asking when it comes to the electronic health record? And frankly, I was pretty shocked when I saw this number move. I didn't think that this would move, and I thought this would keep getting worse and worse and worse. But in fact, we are showing that it is possible to reduce EHR-related burnout, and Pete will talk more about that. Outpatient is much more burnt out when it comes to EHR-related burnout than inpatient. And then the CMIOs gave us a laundry list in a prioritized order that we asked our thousands of physicians and APPs to choose from and to find out which are the top drivers of EHR-related burnout. And this is just fantastic, phenomenal data that our CMOs and CMIOs are working on. And again, I'll let Pete talk about the real case example from Essentia. But you can see, what's making EHR not work for the clinician and their patient. Here's a couple of quizzes for you. Do some myth busting here. And again, just kind of answer these questions in your head, and then I'll show you what our data shows. Do you think there's a difference between physicians and APPs when it comes to burnout? So who do you think is more burnt out? So answer it in your head. 2017, APPs were less burnt out than physicians by over 4%. However, last year, they were the same. Next question. Do you think there's a difference between inpatient and outpatient clinicians? Please take a second to answer it. Who do you think is more burnt out, inpatient or outpatient? And I hope you all answered correctly because this is something we all know. Outpatient way more burnt out than inpatient. Primary care is in crisis right now, and I hope that you all are responding to it like we are in Minnesota. Do you think going part-time helps with burnout? So again, take a second. Who do you think is more burnt out, full-time or part-time clinicians? No difference. Or maybe a percent point difference between full-time and part-time. In fact, we're not seeing big differences if you go part-time. So again, that's something for us to reflect and ponder on. This particular one is interesting. Do you think employed clinicians are more burnt out or independent clinicians? Again, take a moment to respond in your head. 2017 data, they were exactly the same. And to our surprise, and this is why you need data and longitudinal collection of data, last year we saw a movement. So now that we have a movement, we have some gold in this mine that we can learn from, and we are. We're trying to figure out what's going on here. Why are the independent clinicians less burnt out than employed? And again, you will agree that this is phenomenal to try to test some hypotheses and try to learn and dig into as we are. Again, this, hopefully everybody will answer this one correctly. Who's more burnt out, married or non-married clinicians? Again, plays out across industries, not just healthcare. And then finally, I hope that you will all be able to answer this one correctly as well. We do have a very significant gender difference in burnout between females and male clinicians and healthcare staff in our industry. I'll finish my data tsunami with yet another data point that has been that we've been very curious about, and now we have data. So we're looking at different age brackets, and you will see that boomers, how boomers compared to Gen Xers and millennials. Boomers are the least burnt out, and then when we dig into it, it's pretty fun data to look at. Millennials are the ones that say work-life balance is their top driver, and then when you look at boomers, meaningful work is the top driver there. So again, very robust data that we are having a lot of fun with. Finally, before I turn it over to Pete, I'm going to show you one comment. I invite you to take a deep breath because it's a difficult comment, and it has been edited so that the person that wrote it cannot be identified at all. But the gist is right there. This is somebody here in Minnesota that is serving our communities and our patients, and this is what they said, and this is why Pete and I and hundreds of people are just battling this crisis in our industry. So our approach is similar to the white papers that a lot of organizations have put out. There's a lot of consultants and a lot of folks out there that are spitting out white papers and calls to action. We let all of that roll off of our backs as we keep our head down and focused on making the practice of medicine and healthcare better in Minnesota. So this is our model. Imagine all these rowers. This can be a clinic team. Do you work on the rower themselves? Do you tell the nurse practitioner every time you see a difficult patient, after you see them, go out, there's a meandering path outside the clinic, take a break, go for a 15-minute stroll? Do we teach them deep breathing exercises? Yeah, maybe there's some role to individual resiliency, but that's not our model. That's our lowest priority action. What we are focusing on is the leadership and the accountability of leadership. So our CEOs, our CMOs, our leaders take this stuff very seriously. So that's strategy number 2, the accountability of leaders such as Pete Henry, who's going to speak in just a minute here. And the top action, though, is to make the weeds in this water disappear. It's the electronic health record. It is the nonsensical and ridiculous quality measurement that does not improve patient care. It's all of those weeds that we are slowly but surely trying to cut away, and that's where quality and our advocacy through, with the help of AHA and our other partners nationally and here locally, that will help clear some of these weeds out so that this team, in fact, can row from point A to point B. And this is a much nicer representation of that same model. Again, we are in the top 2 strategies here, and that's what we are doing statewide. We're really not focusing on the individual. We are leaving that to highly paid consultants. With that, I will turn it over to Pete to answer this question that you may have. Very eloquent, beautiful data. You're talking a big game here. So, is it working? Pete?
Thank you, Rahul. I appreciate the opportunity to speak with all of you and kind of share my own personal journey with this and also my professional journey with this. And as most of us know, the burnout issue is not new. I've been in medicine now going on about 35 years. And I can tell you I'm boarded in family medicine, but I practiced clinically emergency medicine for about half of my career full-time before moving into community administration. But when I was in family practice, I was a sole provider in a single clinic with a receptionist and a nurse. And, at the time, I didn't recognize the symptoms and signs of burnout that I was experiencing. But what it did result in, it didn't result in a complete career change. It resulted in a specialty change. I moved from emergency medicine or family medicine full-time and part-time emergency medicine along with hospital work, delivering babies and doing newborn care, to eventually moving into a full-time emergency medicine practice. And a lot of it was around that work-life balance, because I always had felt that I'd been a very engaged physician, and I think that statistic where there's a clear correlation, and there's multiple studies that show this, that there's a clear correlation between engagement and burnout or resiliency as well. So go to the next slide, please, if you would, Rahul. So we here at Essentia, I've been very proud of the results of the response rates. You'll see in our first year we had a 55% response rate, which, as Rahul stated, that kind of the national average and something like this would be around 19%. And did quite well the second year, but I've seen a drop-off, but still significantly better than the statewide average, which was at 23%. Part of that, I think, goes to the importance of if you do this work and you start to survey your physicians and APPs, you really have to have ownership in that. And that's part of the key work that I've done with Rahul and the rest of the CMOs, is taking this on as a personal journey because of the importance of it, recognizing that my role as a CMO in driving quality and safety is key around having productive, happy, resilient physicians and APPs in the organization. So we put a lot of time into how we communicated these surveys. They came personally from myself and then the other CMOs within the markets that serve in the Essentia. And in that, one of the key pledges that we made was that we're not going to survey you to death. That's one of the reasons we kind of took a year off this year. And secondly, that if we did get your responses, we were not going to do anything. We were going to do something with them. Because the worst thing you can do is go out and ask for people to give you feedback, information, and then do nothing. You're going to see a definite downturn in what you're trying to do. One of the things that were started behind the eight ball, so when I first took on my role here as the CMO in the Central Market about 7 years ago, I came into an organization along with a new president where our engagement surveys through, at that time, what was called the Vital Signs Survey, were at the 1% for the market that I was working in. And then I'd love to tell you that 1% is at the top, but we're at the bottom 1% in the country compared to our competitors across the nation. I'm proud to say that in that time frame now we are up to 67th percentile. So there's been a lot of work around getting our physicians and APPs engaged. But with that engagement, I think it's become the challenges of increased burnout and decreased resiliency as well. Next slide, please. So in our framework, what we did is we had active engagement in the repeated burnout survey. And I think I can't stress this enough. Having sponsors to drive this work and having somebody who's dedicated to making sure that you do get responses, because I personally sent out 4 different reminders to all of our APPs and physicians asking for their responses to the survey, and I think that reflects in how well we did with that. We also had input in regard to the design survey through the Minnesota Hospital Association and our administration. The survey invite was tailored in context, and as I said, We really pointed out that we were going to do something with the information that we compiled. And the other interesting part of this is that you get, along with this, personal, specific free text information. And we got single-spaced, multiple pages of responses that we've collated each year to try to get into different themes. And then we took that thoughtful reflection on the data and the presentation. We reviewed it with our senior leadership, and then we developed action plans around that as well. And these action plans, and I think this is one of the things that we can learn from, were designed primarily by senior leadership input, without a lot of, and then taking the basic themes that came out of our surveys. But we didn't develop, I think, small work groups to help say where do we and how do we focus to get the best bang for the buck. And that's one of the things I'll talk about a little bit later, what we're changing that we didn't do initially with the first 3 years of the survey. And then the data is presented at what we call our all-provider meetings and senior leadership meetings in each market. And some of the initiatives that we've had for different fiscal years have focused around some of the data and how we improve resiliency and decrease burnout. And we organized a burnout strategy teams for each market. And that's something that we have struggled with. I'd love to tell you that everything has gone well when we've started this whole plan, but we've struggled finding leaders who want to lead the resiliency and burnout reduction and resiliency increase teams. But we've struggled finding people that are dedicated. Most of them are people later in their career that are kind of waning out of their practice. It's been hard to get some of our millennials engaged into this work as well. And then we've added this to our organizational priorities. And one of them is we used to have 6 values in our organization. We now have 7. And the 7th value that we added was joy. Another word that I think you could substitute for that would be gratitude, helping people understand that there is joy in medicine and what we do, and we can get great gratitude for what we do for our communities and people that we serve. And then we're committed as a senior leadership team to keeping this at the forefront. We don't want to start something and let it fizzle, and I can tell you that I'm fortunate to work in a dyad relationship, and my dyad, Sheila Hart, who's our Vice President of Integrated Services, has been a wonderful support to me to help us drive some of the work that we're going to talk about here in a little bit around our EMR optimization. So next slide. So if you look at our national comparison, this is our own personal data. You can see that this isn't a complete success story. And the last survey, which was done in 2018, you can see that we've had a slow uptick in our burnout. But we've also had an increase in our engagement. And so if you look at the data that Dr. Koranne had referred to earlier, more engaged people are at greater risk of burnout. The other thing that this data, I think, reflects is that initially we hadn't put into place some of the key things and initiatives that we thought would help reduce the burnout based on the information we got from our survey over the 3 years that we participated. Next slide. We have 3 markets. The central market is the smallest of the markets, about 10% of our organization. The east is the largest, and that's about 60% of our organization, and the remainder is made up in our west market. And as you can see, there is improvement, kind of a salad of where our responses are. We have struggled in all of our markets in emotional exhaustion, depersonalization, and burnout compared to the state average. Next slide. So what Rahul had referred to earlier, the thriving factors and where you should try to focus your energy. And I look back at when I first took on the role 7 years ago, and some of the resiliency work that wasn't as integrated was really by market and not a system-led initiative. A lot of it was focused on recognition, social connections, fairness, and meaningful metrics around quality and stuff. But as you can see, that really wasn't the key focus. And as we've taken our surveys now, we've learned that where we need to start to focus our energy, and where we've started to focus our energy, is on work-life balance, control, meaningful work as well. And you can go to the next slide. You can see the work-life balance continues to be an issue, and I always think of this constant battle that I have, and I think most of the senior leadership in our organization, as well I'm sure others' organizations, this balance between the work-life, constant reminders that we're getting from our physicians and APPs, and then to balance that with access and productivity, because they don't always go in unison with one another. And we get constantly reminded that we're trying to make them more resilient, reduce their burnout, but in this next breath we're asking them to increase access and increase productivity as well. But we have a very engaged workforce, as you can see, and that engagement levels have actually increased recently, and I believe that is directly correlating to some of our burnout statistics that I've reflected to earlier on. And then we started 2 years ago to introduce some of the data around the EMR, or the electronic health record. And as you can see, for our organization above the state, we are about average as far as moderately high and excessive. We're about where the rest of the state is. We've seen a clear reduction, though, in the last couple of years, and I think that's really important. You see that the satisfactory numbers have gone up, and the moderately high and excessive have gone down, and that's, I think, a direct focus to where we put on EMR optimization with our clinicians, and I'll talk more about that in just a minute. So there's several things that we did around this, and one of the first part in work that we've done, and it's been a struggle getting the clinicians to the table, because we, as an organization, compared ourselves to other Epic organizations. We have Epic as our EMR. And up until we started this work, as an organization, we had 1,500 different order sets that we had to manage and okay and put through our approval process on a yearly basis. And if we compared that to other healthcare systems that are of similar size, that the average there is about 500. So you can see we were almost triple. And it reflected that we are a conglomeration of multiple different organizations over a number of years over a very large geographic area. But we had a lot of work to do in this. And we've worked through about 85% of our order sets at this point in time, the key barrier being getting the clinicians to the table and finding them time to sit down and come to an agreement. But we're now down to about 700 order sets, and we feel that this is going to continue to pay off in the long run as far as increasing resiliency and decreasing burnout. The other thing is the focus on the EMR optimization. We did onboarding and training for all of our new physicians, and when we went as a system from several different EHR platforms or formats to Epic, we did initial training, but what we had not done is this ongoing training. So we dedicated resources and time and have made a commitment to have intensive 2-day on-site training by clinicians at all of our sites, starting out with ambulatory clinics and then moving to inpatient and then specialty clinics after that. And you can go to the next one, please. And then one of the other key information we got from our surveys around the EMR was the in-basket work. And I think back, and I've made this comment before to others, is that when I was purely in family medicine doing part-time emergency medicine work, I didn't have an in-basket to manage because we didn't have an electronic health record. But what I had was 2 hours of phone calls at the end of the day and the paperwork that went with that. And all we've done is taken those phone calls and paperwork away and replaced it with a different form. That's one of the key problems with burnout, and that's the in-basket management. And that was a very consistent theme across the surveys that we've had over the last 2 years in regard to this, that we needed to do something about this, help to take some of this workload off that has now been placed on directly to the APPs and physicians. Next slide, please. So as we talked about, there was input from the CMIOs from multiple organizations in the state of Minnesota and the Minnesota Hospital Association regarding some of the data, and you can see that the statewide data and Essentia Health data is pretty similar. Our organization really wasn't much different than any of the other organizations. The interoperability piece of it, now that most healthcare systems in the state of Minnesota are on Epic platform, was the least problematic for us this last year. Next slide. I'm sorry, go back to that previous slide, please, Rahul. You can see the impact on clinician-patient relationship. That is a very consistent theme. There is a constant, and many of the personal notes that they made talk specifically about I can't interact with my patient. It affects my service scores. My patients don't want me to sit and look at a screen and type on a computer when they're seeing me, and that's something that we're trying to work on with our optimization program. Go ahead.
Pete, there's a question in the chat box regarding, how do you work on this across an organization? Where does the budget come from? And I think that those were some lessons learned for many of our organizations. Would you kindly reflect on that?
Yeah, so when we identified that this was really one of the key drivers in reducing burnout and increasing resiliency, we met as a senior leadership team and made a dedicated effort to say, okay, if we feel that we need to focus on EMR optimization, who's going to do it? Are we going to go outside and get resources? Are we going to have analysts, some of whom have no clinical background, go to the elbow and not really understand the workflows of the physicians, APPs, and nurses? Or are we going to dedicate resources? So we committed as an organization budgeted amounts of money for each market ongoing to this training. And so that, with an understanding that we would have to utilize our own physicians and some of our APPs for the training, we would have to train them if they already weren't physicians. So we've got them off and sent them to builders training. They've gone to EPIC, annual user group, and they also take time and sit on our optimization steering committee and other subcommittees of IT and IS. And so it's really taken not only a financial commitment to this, but a time commitment, recognizing that when you take clinicians out of practice and you're trying to drive access and productivity, that impacts. So it's a balance, but it has been a significant amount of dedicated commitment that all of the senior leadership team, all the way to the top of our CEO, COO, myself, the CMO, and the Chief Financial Officer have committed and are standing behind. I hope that answered your question.
Yeah, thank you, Pete. And then one more thing that maybe, I would love to hear your reflection on. At our physician leadership meetings over the last 4 years, we've had several panels with medical students and residents who are early in their medical career, kind of come and talk to us about, their journeys, their reflections, what are they sensing, and then what is driving them towards this new career that they're learning about, and what are their expectations. So, you obviously have a lot of, students coming through, given you have a very well-run rural residency program up in your shop, but also you have a lot of new residents that that join right after the residency. So just put all of that in context and talk a little bit about how does medical education or nursing education or training kind of play into this, given the significant differences we are seeing in the drivers of burnout between the next generation and the generation that is already here, and then maybe the boomers that are trying to decide when should they exit.
I'm not sure I fully understood or got all of your question, but I'll try to touch base on it. So we do have a family medicine residency program that we're actively participating in our East Market or Duluth market, and we have dedicated training that we ask all of our clinicians to do. But what we've seen and what we've struggled with is that as physicians and APPs become more overwhelmed with the work that they do in patient access and productivity, we're seeing less and less desire to teach and want to be compensated for any teaching that they do, whether it be for nursing students, PA students, nurse practitioners, CRNAs, or even physicians ongoing. So that has been a continued struggle. We have committed a fair amount of money to helping with some of that education. Where there are obviously, I'm going to blank on the name, but there is funding you can get nationally for helping to pay some of your physicians if they're willing to do some of that training, as well as some of the PAs and nurse practitioners can do some of that training and get that. There was also a comment regarding the budgets and how much was allotted per clinician. So what we dedicated initially was more on hourly training. We committed to give them 4 hours at the elbow training with an analyst as well as a physician or an APP physician lead who was going to be doing the training. And when we did the training, we have a team model concept, and so we not only worked with the clinician themselves, but we worked with their team, and that training was incorporated into their team model. They saw a few patients during this training, but a markedly reduced schedule, and then they did it in real time. And ongoing, we have committed 2 hours per year. And the budgeting for this is, like most healthcare systems, although many of our dollars come from pay-for-performance from third-party payers and some CMS, still most of our physicians and clinicians work on a purely productivity or nearly pure productivity model. So they had consternation about saying, you're going to make me take 4 hours out of my day to learn about EMR optimization. I think I'm already pretty proficient, and some said, no, I'm just not willing to do that. But we, in our communication to this initiative, did a lot of change management around using the ADKAR model, awareness, knowledge, desire, and we created that desire recognizing that if we could convince them that if this 4 hours is well spent, the return on investment in reducing their time on the EMR and the improvement in their work-life balance and improvement in their productivity was a win for them, and it was a win for our patients especially, and it was a win for the organization. And as time has gone on, as we've done this, and we're about 1.5 years into it, we are finding that the return on investment is indeed significant, and we've done ongoing surveys internally so that we have metrics that we have developed along the EMR optimization work so that we can show that what we're doing as far as pulling people out of practice, making this a required activity is actually beneficial to them, beneficial to our patients as well. And I think that's one of the key things, make sure that you, as you do this, doing the change management up front to help them understand that investing in themselves actually is an investment in their resiliency.
Thanks, Pete. And, at this moment, I would like to call out and thank Dr. Mike Whitcomb, your Chief Medical Informatics Officer, and his hard work in giving us input and feedback. And I would also like to recognize all the other Chief Medical Informatics Officers from across the state that took time, came to our meetings, helped us come up with a list of this might be what is driving EHR-related burnout, because we didn't know. But now we know what our respondents are telling us and what are the highest priority drivers according to them. And when it comes to data like this, the voice of the end customer or the end user is the most important, and that's why this data is so powerful for us. So, Pete, as I turn back to maybe showing some other data from other healthcare systems, maybe talk a little bit about what other lessons, did you learn? What went well? What was a challenge as you went on this journey, both for you or your organization? I still remember, 4 years ago when we were sitting in the room, kind of thinking about we must do this, we must do it in a data-led fashion. You were there, and we were all starting to think about, what do we do? First, find a tool, then put a project plan together, and then really have accountabilities and metrics, and really do it in a organized fashion. And you were there. So just reflect upon, what's gone well for you and the organization, what challenges, come to mind, and maybe for other organizations that are listening in that may want to start this work in an organized way, maybe across their organization or maybe across their state, what counsel would you have for them?
So I'll start out with what didn't go well. And I think what didn't go well when we first started doing this resiliency work prior to looking at actual good survey data is that we kind of took our collective Gestalt experience and said, well, we need to get back to having, the medical staff lounges are gone. Doctors don't meet together. We started to do cohorts where they could meet for lunch or dinner. We would pay for that. We had more journal clubs. We trying to increase that social gathering atmosphere. And what we found out, and we tried to do a lot of information at our all provider meetings about individual resiliency. And we continue to do some of that, but we found that we really couldn't move the bar. So what had gone well was when we started to look at the data that was provided to us internally through our participation in the Minnesota Hospital Association Burnout and Resiliency Survey. So we actually used the data to drive where we were going to focus our energy in those key drivers and identifying them. We also then got what we call our EMR optimization team, and we had two sponsors at the executive level, myself and my dyad partner. But then, as you said, Dr. Michael Whitcomb, who leads our who's our Chief Medical Information Officer, as well as Julie Newman, who's one of our key nurses and nurse managers in our primary care area, along with our IT partners, Dan Barnes and Dennis DeSenko. And they created a steering committee that helped us to make sure that we got input from the end users or the consumers before launching this program. So we used a lot of data that we collected from our surveys, but also we went out and had focus groups to say, well, how do we do this? What will work, what won't work? And then the last thing is just what has worked and takes a lot of time is the commitment to say that you're going to pull people out of practice for a period of time and drive this change. I can tell you just a couple of things that we've done along this as we've gotten good results from these trainings, and we have done surveys and everybody that we've trained, internal surveys of what we wanted to measure. We have gotten phenomenal feedback. There was a provider that at the end of his training, he sent us a note and says, thank you. You have saved my career, and you've given me back an hour of my day, each day of my life. And so it's been a real positive, and I think the key thing, the things that work well, is we've listened to our consumers, and we've acted on the data. If we didn't act on the data, I think we would not be where we are today. And I'm excited for our next survey, as I think we're going to see some significant improvement in that. And the other thing that we're doing now is we're participating in the CLAS Collaborative, or KLAS, which will give us some data nationally about how we're doing on our EMR optimization work as well. And it's not just data within the Minnesota Hospital Association, but it's national data along Epic users going forth. And then the just very last thing is we have something called the Transition to Practice program, which is led by one of our APPs here. And what we do is we have focused onboarding for all of our new APPs, recognizing that they experience burnout very early in their career as well. And that has mentors, they have physician coaches, they have ongoing didactic learning. And by doing that, and it's now in its third year, kind of similarly, it started before the EMR optimization. When we've reduced our APP turnover from initially above the national average at around 14 to 16%, now down to 6 to 7% with that. And so that's been a real positive as well. There, Rahul?
Thank you, Pete. I want to reflect on your leadership in this effort and your voluntary time that you've taken to kind of give us the input from an organizational perspective. You serve currently as the chair of our statewide steering committee, and that's all the stuff on top of a very fully loaded plate. So it's phenomenal to have champions like you that are joining hands together to say, you know, healthcare burnout is a crisis that we need to combat. Our staff, every one of them, you know, even volunteers and leaders and boards, those are the humans in our industry that matter the most. They are ours, and we care about them, and we want them to be joyous at work. So, Pete, thank you for being so steadfast in your commitment and for your engagement and for sharing this story from Essentia. And I know we may have some more questions, so you know, we'll have some more discussion. But I'll move on to
Rahul,
just
can I add just one more quick point? Yeah. You had asked about kind of what work or what's important. I think the change management around this is really important, and making sure that you don't have to use the AdCart tool, but you're using some specific tool for the change management piece. But the other is to making sure that you have into place a very good and strong organizational structure about who's going to help you do this work and how's it going to communicate it, because I can't personally go out to our 2,100 physicians and APPs and say, I need you to attend the EMR optimization. Here's the rationale why. But we have developed a very strong leadership structure. We have a dyad structure, as I've talked about, for all of our section and division leaders. And in that, we keep that organizational chart up to date, and we have supported every one of our physician and APP leaders with an administrative dyad, recognizing that we want physicians and APPs to see patients. And I think having that structure in place of some sort is extremely important before going on such an initiative.
Thank you, Pete. So just a reflection again and a reminder that, burnout is no different than how we attack and you attack sepsis and pressure injury and all the other good stuff that, we are trying so hard to do. It is an adverse event in healthcare, and so the quality improvement model does work, should work, and in fact is working in Minnesota. So a reminder also that part of this is collaborators coming together in a safe space to learn from each other. Collaborators, healthcare systems, small, large, mid-size, saying it is okay to array my bar side by side with my competitor. It is okay to put all of us on this one graph, because at the end of the day, when we discover who these 6 are amongst us, and we know who they are, then we can sit at their feet and learn, because they have the best practices that we can then spread. And also it is okay to know who these 7 are, because transparency is the first step in improving. So we know who these 7 are, and now that we know, we can begin the process of improving. So just a reflection on how this model has really brought the entire state's healthcare systems, all the participants who are participating in this work, together in a very transparent, open way. Again, no different than quality improvement that we are so proud of in our industry. I talked a little bit about that emergency department, so I'm going to close that story out for you. So the least burned out emergency department in the state of Minnesota, and we knew which one it was. We called the chief medical officer, said, hey, would you connect us to the right person or persons? It happened to be a dyad, a physician leader, and an operational nursing leader, and we interviewed them and went and tried to feel and sense what was going on and collect some data through our structured interview process. And I have to tell you, we kind of had an inkling on what was up within the first 2 minutes of that visit. And that was the power of that dyad. I mean, the minute we came face-to-face with them, we knew that they had a big part to play. So that, again, underscores the importance of leadership at all levels of the organization. If they believe, just like these 2 phenomenal leaders believe, that their staff needed to be joyous at work, and only then could the quadruple aim be achieved, that was the beginning, and we knew that had a lot to do with their phenomenal results as compared to the other organizations across the state. Here comes the last tsunami of data for you. Just so I dispel the myth that there's only one organization in Minnesota that is actually improving, and I can actually prove to you how this this model is actually working. I'm going to give you a case study of about 9 or 10 different organizations, and they're all unique and different. Their CEOs and CMOs have chosen different drivers and outcomes to work on, and they've shared their actions with us. And so I just want to leave you with a flavor of what is up in Minnesota, and hopefully inspire you to do something like this on a statewide or a much broader scale. We can do this. We can do this. All right. So here comes large system number 1. 1 year, 5% drop in self-reported burnout, not easy. This is kind of like Press Ganey or one of those other surveys where a 0.5% improvement takes years. This system, because the CEO, because the CMO, because their leadership believed and focused, they were able to achieve. And then we know what they did, because we know the actions they took. We know they worked on the quality platform. They dedicated time to developing and growing physician leaders. They improved on EPIC functions. And by the way, Pete has talked about EPIC. I just want to underscore, I'm we're very pleased that Epic is starting to contemplate and take some actions around burnout, and they're trying to be a part of the solution. So I commend Judy and her team on turning her attention to Epic and EHR-related burnout. So that's a reflection. I hope we can keep pushing on that together and improving. All right, mid-sized system, they worked on the overall burnout outcome, and again, phenomenal results in 1 year because they took some actions, and we know what they are. And here they are. This was a fun one, a provider-specific EAP, and again, do you need that? Is that, should we think of physicians and clinicians as a part of the team? It's a fantastic question, and this also underscores why the human resources leadership and human resources division needs to be in lockstep in leading this strategy, and the clinical leaders and the operational leaders need HR to be a part of this strategy. So really pleased to see that effort at this mid-sized system. This small system, I mean, wow, look at that. And you may say, well, the N size must have been small, and my response to you would be, oh yeah, if the N size is small, then every vote counts. And so in that particular organization, it's even more challenging, I would argue, to get this kind of results. And they did it. They did it. And these are how they did it. Here's another small system, a different one, that worked on and wanted to focus on electronic health records. Again, like Pete and Essentia Health, they moved the dial. Dictation from cell phone and getting that capability. So again, gals and guys, this is not rocket science. It's listening to your front lines and responding, and the dial will move as it did for this organization. This mid-sized system, a different one, and they're all different, as I promised you, wanted to focus on stress as a driver, and look at that in 1 year. Another small system that wanted to work on stress, significantly increased the number of their frontline clinicians who strongly disagreed that they were feeling stressed. I mean, that's pretty phenomenal in 1 year. Values alignment was the driver this small system chose, and again, improved in 1 year. This is another mid-sized system, significant improvements. Dyad leadership model was one of the interventions they put in place. Involved physicians in strategy, not just in memos and in words, but actually operationalize that strategy. Care team efficiency was what this small system leadership wanted to work on for this year. And look at that, in 1 year. And here are some of the actions that we are recording and trying to match up with the outcomes. Here's another mid-sized system that wanted to work on care team efficiency. And actually, this one slipped in, so I want to recognize Douglas County Hospital and their CEO and Chief Medical Officer, both of whom I know, and they're doing great work. And so again, it can be done if you focus and operationalize the strategies. This one is from Allina Health. Again, that kind of the block didn't quite work, so it gives me an opportunity to recognize Dr. Tim Seeloff, who is the chair of our physician leadership gathering across the state, and also serves on our board of directors as the Physician Leadership Council's representative. So, he's had a big part to play in this strategy, and so this is the results from his organization. Again, big ships are difficult to move, but they're doing it. So in summary, as you contemplate an organized way to combat and battle burnout, because it is real, we know it, I see it, Pete sees it, I know you all see it, especially those of you that are at the front line. Go to a clinic, go to a hospital, go to a nursing home, and just sit there for 5 minutes and look at the humans around you. You know this is real. So the way to attack it in an organized fashion is to convene a guiding coalition, folks like Pete Henry, folks like Tim Seeloff, who believe that collaboration is key, who believe that data and a quality improvement organization is the way to attack this. And then get the right data analytics platform, get the data, commit to collecting it on a repeated fashion, commit the top leadership who will give you the data, who will act as champions locally, and collect not just frontline but also leadership data. So that's a must-have in a summary if you want to do it in an organized fashion across your organization, across your state, or across the entire country. Second, this is collaboration at its best. Quality, safety, and healthcare burnout is not something healthcare systems in Minnesota will ever compete on, and that's why we have all of these organizations joining forces to work on this. So it exemplifies broad collaborative action that we are so proud of over the last 4 years. Again, a reminder as we close on the model, we surveyed the frontline clinicians. We had a massive machine of plan, do, check, adjust, celebrate cycle happening across the state, which was spurred by data and repeated data from the front line and also from the leadership about the actions they were taking, so that we can start marrying those two things up to say what's working and what should we abandon, what's working and which actions should we not do ever again. So that's what we are learning, and collaborative learning and sharing across organizations, which is just so thrilling to watch and which Minnesota is so proud of. And then finally, our model, again, not a fancy white paper here, not a fancy call to action here, not a fancy document with lots of tables, just a simple canoe with rowers. And your clinic teams and your skilled nursing facility teams and your hospital teams, this is what they do. They show up, they take care of patients, they row hard. So we've decided not to work on the muscles of the rower. We leave that to them, their families, and their social support networks, but we are attacking and we are putting the leaders accountable for joy in practice and joy in healthcare. So our strategy number 2 is hold the senior leaders like Pete, like his CEO, Dave Herman, accountable, and they are choosing to be accountable for improving healthcare burnout at their organizations because they want to and they believe it's an imperative. That's strategy number 2. And strategy number 1 is really trying to get away from nonsensical quality measurement that does nothing to improve patient care, from electronic health records that demand pajama time, from systems that are not interoperable, and on and on and on. Those weeds in the water, we are cutting them away slowly but methodically, and as a result, I think we are seeing some improvement. So that's our model, and it's not perfect, but that's what we have, and we are very encouraged that we're starting to see some results. So with that, both Pete and I invite you to join this battle, to join this journey in your own way, shape, form, at your clinic, at your nursing home, at your hospital, at your payer organization or wherever you are, or if you want a collaborative across organizations, that's great. If you want to do it across your entire state, that's fantastic. And if somebody from CMS is listening in, if we can do this across the country, that would be pretty phenomenal. So again, join the fight. Thank you so much for attending today, for your comments and your questions. And Pete, I will invite you to say some last words.
No, I just wanted to thank you for all the work that you've done, and I'd like to recognize Rahul and his phenomenal leadership of the Minnesota Hospital Association. Without his dedicated work in this area, enthusiasm and energy, I don't think it would have been accomplished. And all of our facilities and systems in the state of Minnesota better off because of the work you're doing.
Pete, thank you for those words. Thank you to all the participants across the country and for your questions, the words of encouragement and counsel. We truly appreciate it. Have a wonderful remainder of the week. And again, as both Pete and I said, join the fight. Elisa, back to you.
Thank you so much for that incredible deep dive through the work that you've been able to do this over the last few years, and especially Pete, thank you for sharing the work being done at your organization, and Rahul for really leading the fight, the charge across Minnesota. So this is the last webinar for 2019 for AHA Physician Alliance, but we do have a full schedule for 2020 that'll be up on our website shortly. So I wish everyone a happy and peaceful holiday season, and thanks